Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. The drug of the day today is going to be Captopril. But before we get to that, I want to make sure you go check out reallifepharmacology.com, get your free 31-page PDF on the top 200 drugs. Great study guide, great refresher. Simply an email is all that it will cost you. So no brainer to go grab that at reallifepharmacology.com. We also get you updates when we've got new podcast episodes available as well as other free content. All right, so getting into Captopril. Brand name of this medication is Capitan. This is an ACE inhibitor. As a reminder, ACE inhibitors competitively inhibit angiotensin-converting enzyme. Now, what does that enzyme do? So, angiotensin-converting enzyme does what it says it does. It converts angiotensin 1 into angiotensin 2. And angiotensin 2 is really the big important thing to remember here. This is a potent vasoconstrictor. So if we have less of the vasoconstrictor angiotensin 2, we are naturally going to cause vasodilation and help lower blood pressure, which indeed is what Captopril is used for. Dosing. So one of the major strikes against Captopril, and probably why you don't see it too often in your practice, or at least most practices, it is dosed frequently. So it's anywhere ranging from 6.25 milligrams up to 50 milligrams 3 times a day is kind of the usual standard dosing. The indications, hypertension, of course, but we've also got some of those compelling indications that go with other ACE inhibitors as well, such as CHF, ACS, and proteinuric chronic kidney disease. Also wanted to mention with dosing that if renal function has declined and you're giving this medication on a chronic basis, there is a need for dose reductions, and usually we just reduce the frequency. Like I mentioned, it's normally dosed probably 3 times per day in most situations. But as renal function declines, we don't need to dose it quite as frequently. So my marker for Captopril is around 50 mils per minute. You start dipping below there, and you may likely want to reduce the frequency that we're giving it just because it's going to hang around and last a little bit longer. There is one other thing with kinetics, and I'll take a deeper dive into kinetics in a little bit here, but I wanted to mention administration when we're giving this medication. And again, kind of another little strike against it, if you will. It needs to be administered 1 hour before meals. I guess that's a relative needs to be. The reason why it's recommended to be given an hour before meals is food actually reduces absorption significantly. It's in the range of 30 to 40%, I believe. So with that comes another strike against Captopril for sure. So that can definitely be a downside, that if you take it with food, you aren't going to get kind of the full dose or full effect that you'd typically get. All right, let's get into adverse drug reactions. So first and foremost, absolutely should not be used in pregnancy. It is toxic to the fetus and can cause fetal harm. So if you've got a patient who becomes pregnant, they're taking this medication for whatever reason, it absolutely should not be taken, and the patient should be transitioned to something else. Adverse drug reactions, ACE inhibitors in general, so cough, ACE cough, that can happen certainly with Captopril. To resolve that, typically we switch to an ARB for blood pressure management there if they haven't tried it and if that would be tolerable for them. Of course, we've got a dip in blood pressure. If we reduce the blood pressure too low, patients can get orthostatic hypotension and dizzy and things of that nature. Elevations in potassium, hyperkalemia is something obviously we're going to monitor and pay attention to. Angioedema risk, so swelling of the lips, throat, that is also a reported adverse effect with captopril. Acute kidney injury can happen with ACE inhibitors. Sometimes people get confused about using it in proteinuric CKD, and why would I give this medication if it can cause acute kidney injury? Well, it helps delay the progression of those renal issues, but in the setting of AKI, if we give too much, or a patient is intolerant of that dose, or we have other medications that increase that risk for AKI, it can induce an acute kidney injury. And the reason being, mechanistically, is it essentially reduces the pressure in the glomerulus, and it does that by vasodilation of the efferent arteriole. A couple other rare things that's at least one of these, lower white blood cell count, neutropenia, bone marrow suppression, that is fairly unique to captopril compared to other ACE inhibitors. So that's kind of a little bit of a differentiator there, where that may be a little bit more of an issue with this medication. And then rarely skin reactions have been reported as well. Black patients may have a reduced response to ACE inhibitors in general, so that's definitely something to pay attention to if we start this medication and we're not seeing much of a reduction in blood pressure. My first thought is always adherence. Are they actually taking it? And then my second, another consideration here with captopril or the use of ACE inhibitors in general, is that patient black? They may have a lower likelihood of responding to ACE inhibitors and dropping that blood pressure. And I don't think there's a solid, well-studied mechanism for why exactly that happens. There are some theories on that, but I don't think anything's ever been fully proven with why that is the case. Monitoring parameters, just touch on those briefly. So creatinine, renal function, obviously, potassium, and blood pressure. Those are going to be the three things that you're probably going to monitor with this medication. Kinetics, let's talk a little bit about that. So captopril actually has a very fast onset. With that said, it also has a very short half-life, which that short half-life explains why we need to dose it multiple times per day. So that can definitely be a big challenge. Max effect with this medication is in the 60 to 90 minute range. However, if we're managing chronic blood pressure, it may take a few weeks to kind of get to that maximal blood pressure lowering effect. And this is why in hypertension clinics and things of that nature, it's usually start a medication to reduce blood pressure, and then typically that follow-up is going to be in the range of 2 to 4 weeks to make sure they're tolerating it, maybe do follow-up lab work depending upon what we're using, and certainly lab work would be necessary with captopril, with the renal function and potassium there. But I think that gives you a little bit of knowledge surrounding the kinetics and why it's dosed the way it is there. Also wanted to allude to the fact that there is a significant amount of this medication that is eliminated in the urine unchanged. And generally, when that's the case, we need to dose adjust this medication for renal function. And again, I alluded to that in the dosing earlier, but that's the kinetic reason and kinetic purpose for that. Again, usages, I wanted to mention that with the faster oral onset, there may be a little bit of a role for captopril in like acute hypertension, maybe within a healthcare setting where maybe IV isn't warranted or justified. Clonidine is an agent that's oral clonidine is an agent that's sometimes utilized in that situation. Captopril, with its faster onset, may be a consideration for an alternative there to drop that blood pressure acutely, again, without having to use IV medications. Now, if we're in an emergency room, hospital type situation, it's like, okay, well, we're probably going to be using IV blood pressure lowering medications if we need to get that blood pressure dropped very, very quickly. So, but maybe just a little side roll where you may see Captopril, depending upon the practice you're in there. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like NAPLEX, BCGP, ambulatory care, pharmacotherapy, go check out med101.com/store. We've got a growing list of resources there that will definitely help you prepare and pass your board exam. If you're a nurse practitioner, PA, med student, nurse, we've got plenty of other resources as well. Book on polypharmacy, which has been very popular for clinicians. Book on drug interactions in primary care. So lots of different options there for you to check out. And again, all those links at med101.com/store, and your purchases go directly to support this podcast. All right, wrapping up with drug interactions. So first and foremost, I'll just cover the obvious ones quick. So other medications that lower blood pressure can have an additive effect on Captopril, which I've certainly covered numerous of those in previous episodes on antihypertensives. Same thing, opposing blood pressure elevating medications. So something like a stimulant, for example, can raise blood pressure and essentially counteract the effects of what we're trying to do with Captopril. Potassium interactions, I think these are important to remember. I definitely have had cases of significant hyperkalemia with ACE inhibitors like Captopril combined with the antibiotic trimethoprim. So I definitely have seen a case or two where that's caused significant hyperkalemia. Obviously, other meds, spironolactone, ARBs. Hopefully, we'd never see an ARB used with an ACE inhibitor like Captopril, but I certainly have seen that occasionally in practice by error. Heparin's another medication that may have some elevating potassium properties, so that's maybe something to keep tabs on there as well. Lithium concentrations, so lithium for bipolar disorder, they can go up with the use of ACE inhibitors. So we may have to check levels, monitor for toxicity, and or potentially reduce dose, depending upon where we're at with drug levels and how the patient is responding. And then nephrotoxicity. So definitely remember diuretics and NSAIDs. So combining diuretics and NSAIDs with an ACE inhibitor can significantly increase the risk for acute kidney injury. So definitely follow that closely. If we've got to add NSAIDs, we've got to add diuretics on top of an ACE inhibitor like Captopril. Really pay attention to those labs. Monitor closely. Use lower doses if possible, shorter periods of time. All those good principles to prescribing drug therapy and using drug therapy. And then sacubitril I did want to mention specifically. So angioedema. Again, sacubitril valsartan, Entresto is the brand name product there. Hopefully, we're not using that with an ACE inhibitor like Captopril, but if they were given together, one of the reasons we avoid it is it increases the risk for angioedema. All right, well, I think that's going to wrap up the podcast for today. Do us a huge favor, leave us a rating, review on iTunes or wherever you're listening. We greatly appreciate that. Support the sponsor, med101.com/store. Plenty of books, plenty of options to check out there for your general education or for some of you who may be taking board exams there. With that, if you want to track me down, got suggestions for a podcast episode, mededucation101@gmail.com, or you can find me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Thank you so much for listening, and I hope you have a great rest of your day.